working fine or not. Okay. So I guess many of us we know each other pretty well. I'm Dr. Sushant Soni, MBBS MAMC, MD Pathology, Resident Hemato-Oncology, AIMS Delhi. So let us start with our pathology crash course for the NEET MDS exam. Now, before we even go further, देखो बच्चे, for our MDS pathology, it is divided into two segments. Now, for the new students, we'll set few basic rules of the class. The first rule is I am the laziest person. So if I am speaking something, you have to concentrate in the session. I mean, these 3 hours, we'll of course have a 5-10 minute break in between, but these 3 hours are a roller coaster ride in which we'll be covering a lot of content. Firstly. Secondly, I'm extremely friendly. So in case you have any doubts whatsoever, absolutely anything, please write it on the Telegram group in our MDS Made Easy Telegram group, or you can send it in the chat message. Though personally I will prefer it is in the Telegram group, it will be slightly easier for me. Third, it's a very interactive session. The whole point of taking a live class is, if you just listen and write, you're using your 2 senses. If you listen, write and speak, you're using all 3. Interact more. The more you go wrong in the class, I'll be asking you various questions. The more you go wrong in the class, the more you will remember that this is where I went wrong, and you will be marking the answer right. So let's start. Let's keep our fingers crossed, and it's a good day to start because after long it has rained in Delhi, and rain always brings good luck. So on this positive note, let's start with our pathology session. Firstly, pathology for the dental segment, which it is divided into two parts. That is general pathology and hematology. We divide path into 2 main segments: general pathology and hematology. I know you usually say it as general path, but these are the 2 segments in which we will be considering pathology. Next point. So starting with general pathology, starting with general path, and let's start with one of our easiest topics in general pathology, that is cell injury. Let's start with cell injury. देखो बच्चे, normally cell, अच्छा, one more thing, whatever I will be writing, you will be getting this PDF, so don't worry about writing. Concentrate more on listening to this. Before we have our next session, that is pharmacology, we will be ensuring that you are able to download this content as such. You can have this in the printable form with you, and your life will be much more comfortable. So let's start with cell injury. देखो, normally cell is in a state of homeostasis. Homeostasis means it's able to do all its functions well. In case of an injurious stimulus, it undergoes cellular adaptations. It tries to adapt itself. Now, there are 4 main cellular adaptations: hypertrophy, hyperplasia, metaplasia, and atrophy. There are 4 main cellular adaptations: hypertrophy, hyperplasia, metaplasia, and atrophy. If the cell is able to adapt itself, fair enough. Otherwise, it undergoes cell injury. Cell injury can be of 2 types: reversible and irreversible cell injury. Irreversible cell injury is further of 2 types, that is necrosis and apoptosis. It is further of 2 types, necrosis and apoptosis. So let's start with our first cellular adaptation, that is hypertrophy. Hypertrophy, is it an increase in size of cells or number of cells? Hypertrophy, which it is an increase in size. It is an increase in size of cells. How do we know that? Rank 1 to 3. Everybody gets 1 trophy only. Trophy तो एक ही मिलती है, but the size of the trophy is different. So it is an increase in size of cells. Next, so you tell me. I'll be putting numerous polls in the Telegram group. Please do keep on answering in those polls. So hypertrophy is a feature of dividing cells or non-dividing cells. It is a feature of dividing cells or non-dividing. Everybody keep on answering side by side. All the polls that I'll be putting will be in the Telegram group, though I can put a poll here also, but one of the issues here is कि screen थोड़ा सा ऐसे आ जाता है, so it's slightly tougher to create a poll here. So hypertrophy, it is a feature of dividing or non-dividing. Think of it yourself. Which is the size of the cell is increasing. Number is not increasing now. So it is a feature of non-dividing cells. It is a feature of non-dividing cells. Next point, because if the cell was dividing, the number would have increased. It is a feature of non-dividing cells. Next, it predisposes to malignancy or does not. For malignancy or cancer to develop, the cells need to divide. This does not predispose to malignancy. This is a feature of non-dividing cells, does not predispose to malignancy. Next point, examples. Acha, before we go further, let's have a look at the classification of cells. I can divide cells into three categories. That is labile, stable cells, and permanent cells. I can divide cells into three categories: labile, stable, and permanent. Labile cells, these are continuously dividing in nature. They continuously divide. Stable cells, dividing and non-dividing. They divide under stress or injury. Versus permanent cells, which are non-dividing in nature. Next point. Which are the examples of permanent cells? Which muscles? You know that there are three muscles: skeletal muscle, smooth muscle, and cardiac. Which are permanent? Skeletal and cardiac muscle. Skeletal muscle and cardiac muscle are permanent cells, and versus smooth muscle, which is a stable cell. Another example of permanent cells are the neurons. Other examples are neurons. Obvious. That is why skeletal and cardiac muscle. That is why in case of myocardial infarction, in myocardial infarction, there is permanent damage to the heart. It's a permanent cell. In case of road traffic accident, there is permanent damage to skeletal muscle. Neurons, all these are non-dividing. Versus stable cells, which divide under stress. That is smooth muscle. Cells of kidney, liver, and pancreas. They divide under stress. That is why a live organ transplant is possible in case of liver. Liver transplant, I can donate close to 75% of my liver to my relative in case he has had a failure. It divides under stress. And vascular endothelial cells. These are the stable cells. So again, you tell me, out of these three, which cells will undergo hypertrophy? Labile, stable, or permanent cells? Which cells? I've just started the poll again. Which cells are the ones which will be undergoing hypertrophy? Labile, stable, or permanent? It is the permanent, or it is the non-dividing cells which undergo hypertrophy. It is the permanent cells which will undergo hypertrophy, because hypertrophy is a feature of non-dividing cells. So coming back to the examples of hypertrophy, we have seen that the examples will be cardiac muscle, skeletal muscle. So the first example is cardiac adaptations in hypertension. Next example is skeletal muscle. Next example of hypertrophy is skeletal muscle of bodybuilders. It undergoes hypertrophy. These two are obvious. Next, put a star. This is where mainly the question comes from. Uterus. Pregnant uterus, it is how much larger as compared to a non-pregnant uterus? Again, I'm waiting for your answer on this. Pregnant uterus, it is how many times larger as compared to a non-pregnant uterus? Which it is 3.5. It is 3.5 to 4 times larger as compared to non-pregnant. So when the pregnant uterus is there, uterus in pregnancy or gravid uterus, gravid uterus, it is combined hypertrophy plus hyperplasia. Both number and size of cells is increasing. It is combined hypertrophy plus hyperplasia, but mainly it is an increase in size of cells. It is combined hypertrophy plus hyperplasia, but predominantly hypertrophy. Lastly, breast. I mean, something that we guys are pretty excited about, I guess. Breast. Now I can divide the female cycle into three phases: puberty, pregnancy, lactation. In the first two phases, that is in puberty and pregnancy, both number and size increase. In the first two phases, that is breast in puberty and pregnancy, both number and size increase. It is combined hypertrophy plus hyperplasia. Versus by the third stage, that is breast in lactation, the number has increased sufficiently, it is only an increase in size of the cell, it is hypertrophy only. So these are the examples of hypertrophy. The lower 2 points are the main ones which are asked in MCQs. The upper two are obvious, the lower two are asked in MCQs. This is hypertrophy. Next, this gets us to the next cellular adaptation, that is hyperplasia. Hyperplasia, it is an increase in number of cells. So it is seen in dividing and non-dividing. Of course, it is seen in dividing cells. It is an increase in number. It is seen in dividing cells. And because the cells are dividing, it predisposes to malignancy. Hyperplasia. Examples. Now, hyperplasia on the other hand is much simpler and straightforward. I can divide hyperplasia into two types: physiological hyperplasia and pathological. In physiological hyperplasia, the first example that comes to my mind is the normal endometrial hyperplasia. देखो बच्चे, the first example that comes to my mind with respect to physiological hyperplasia is the normal endometrial hyperplasia. You know that during the normal menstrual cycle, there is a proliferative phase, secretory and menstrual phase. In proliferative and secretory phase, the number of cells are increasing. Endometrial hyperplasia, physiological. Next, physiological hyperplasia. Where do the cells continuously keep on increasing in number, continuously dividing? Bone marrow, erythroid hyperplasia. RBCs, they continuously divide. We'll be seeing that in hematology. Next example. This next is, remember which cells will undergo hyperplasia? Labile, stable, or permanent? That is the stable cells. The classical example of which was liver. Liver has unlimited capacity for regeneration. The next example is hepatocyte regeneration. Next example of physiological hyperplasia, hepatocyte regeneration. Hepatocytes, they regenerate, they increase in number. Hepatocyte regeneration. Physiological. Okay. Next. I know a few students are messaging that can't join. कोई बात नहीं. We'll be continuing. So this is physiological hyperplasia versus pathological. The classical example of pathological hyperplasia is atypical endometrial hyperplasia. देखो, see the language of the question very well. If it is the normal endometrial hyperplasia, that is physiological. Normal is seen in the normal menstrual cycle, it is physiological. But if it is excessive, if it is atypical endometrial hyperplasia, it predisposes to endometrial carcinoma. Next is BPH, benign prostatic hyperplasia, it is pathological. Achha, before I go further, tell me something about BPH, benign prostatic hyperplasia. I am waiting for you to tell this. Benign prostatic hyperplasia, seen in young or elderly? Just give me 1 sec, bache. Just give me 1 sec. I need to reply to a message. Mankidu, totally agreed. Just let me reply to Anu because he's slightly upset. He's not able to join because joining is not possible after the session has started. It's not possible after session started. It's a feature of app in free class. This recorded will be available. Just 1 sec, friends. Just 1 sec. Will be okay. So coming back, BPH, totally agreed. It is seen in elderly. Next, the problem in benign prostatic hyperplasia. The problem is that the prostate is enlarging in size. Urethra passes through the center of it, as a result of which the urethra is compressed, leading to painful micturition. In elderly male, the bladder is contracting. He wants to void. The bladder is contracting, but urethra stenosed, as a result of which it is associated with painful micturition, increased frequency, painful micturition. Next, increased frequency of micturition, especially at night, increased nocturnal maturation, and incomplete emptying of bladder. The bladder is not completely empty. Incomplete emptying of bladder, because the urethra is stenosed. The elderly male will have to exert a lot of pressure to empty his bladder. Incomplete emptying of bladder. So what is the problem because of that? If the urine is left in the urinary bladder, urine is a good culture medium for organisms to grow, thus increasing the risk of infections. This is BPH. Benign prostatic hyperplasia. It is a pathological hyperplasia. We'll be doing all this when we study general surgery, not at present. So this was our second cell adaptation, hyperplasia. Hyperplasia. Next, this gets us to our next and a very important cell adaptation, that is metaplasia. Please have a good look. Metaplasia. Metaplasia means one lining being replaced by another. The classical example of metaplasia is Barrett's esophagus. The classical example is Barrett's esophagus. Barrett's esophagus, in the normal stratified squamous epithelium, in Barrett's, the normal stratified squamous epithelium of lower one third of the esophagus, normal stratified squamous epithelium of lower one third of the esophagus is converted to columnar. It is getting converted to columnar plus goblet cells. It is getting converted to columnar plus goblet cells. This is Barrett's esophagus. One lining being replaced by another. Normal stratified squamous epithelium, the lower one third of the esophagus, being converted to columnar plus goblet. So you tell me, I've just started the poll. Barrett's esophagus is columnar metaplasia. It is which metaplasia? Columnar, cuboidal, intestinal, या squamous metaplasia. Barrett's esophagus. It is which metaplasia? Columnar, cuboidal, intestinal, या squamous. If you get a hang of this, you will never forget it. The word before metaplasia is the end lining. So squamous to bilkul out hai. Squamous is totally out. We will not call it squamous. The normal stratified squamous was changing to columnar plus goblet cells, making this as an example of intestinal metaplasia. Making this as an example of intestinal metaplasia. But please don't call it as columnar. I know majority of you fell in that trap and called it columnar. No. See, there are a few golden rules to marking MCQs. The first is never mark the answer as A until you are sure that answer is not BCD. I mean, I have graduated from the top 3 medical colleges in India by these simple fundas. Answer is never A until you are sure that it is not BCD. A is usually the tricky option. Next, if you are unsure of an option or if you are unsure of an answer, mark the answer as C, and probability is higher that you will be right. Follow these 2 simple rules, and even if you are right in 2-3 questions because of these 2, the rank is going to jump drastically. Because of the presence of goblet cells. It is not columnar, it is intestinal metaplasia. Next point, Barrett's esophagus. The main risk factor for Barrett's esophagus being GERD, gastroesophageal reflux disease, GERD. There was gastroesophageal reflux, as a result of which patient ko heartburn hua, patient had pain, patient had heartburn. To prevent that heartburn, the body changes the normal stratified squamous epithelium to intestinal type. It's a cellular adaptation. Barrett's esophagus. Fair enough, but why are we studying it? What is the significance of Barrett's esophagus? Barrett's esophagus, it is pre-malignant in nature. Pre-malignant means it can progress to cancer. Which cancer of the esophagus? Now there are 2 cancers in esophagus, squamous cell carcinoma and adenocarcinoma. It is pre-malignant for adenocarcinoma esophagus. It is pre-malignant for adenocarcinoma esophagus. See, wherever glands are present, wherever columnar lining is present, it will lead to adenocarcinoma. This is Barrett's. So I can divide metaplasia. I can divide metaplasia into two types. Let me write it for you. Into two types. That is epithelial versus connective tissue metaplasia. Metaplasia, which it is of two types: epithelial metaplasia versus connective tissue. Which is more common? Obviously, epithelial metaplasia is more common. Epithelial is more common. Epithelial metaplasia is further of two types: squamous metaplasia and intestinal type. Which is more common? Squamous metaplasia. More common squamous. Intestinal metaplasia we have already seen is Barrett's esophagus. Which are the examples of squamous metaplasia? Answer Vijay. I want you to tell me which is the most common site of squamous metaplasia? Respiratory tract. The most common site of squamous metaplasia being respiratory tract. Most common site being respiratory tract, in which the normal pseudostratified ciliated columnar epithelium of the respiratory tract, normal pseudostratified ciliated columnar of the respiratory tract changes to squamous. Main risk factor being smoking. I mean, nothing is more injurious to health than smoking. So in respiratory tract, normal lining changes to squamous. Next example of squamous metaplasia. First is respiratory tract. Next example is cervix. In which, again, cervix has endocervix and ectocervix. Endocervix, the normal lining is columnar. Normal columnar lining changes to squamous. Why? Because of chronic infections. Answer Vijay. Which is the main chronic infection of the cervix? Answer. Which is the main chronic infection? Which is the main chronic infection of cervix? HPV, human papillomavirus. HPV. Name the low risk HPV. Name the low risk. Tell me the numbers in the Telegram group. I know many students are answering in the chat box, but it is slightly tougher for me to see the chat box because zona thoda sa gadbad aata hai. I mean, I'll get this corrected by the app people, but which are the low risk HPV? 611. Which are the low risk? 611. Which are the high risk HPV? Which are the high risk age groups? As our mothers say, 16-18. Angel, totally right. Totally agreed. They are the low risk HPV. Low risk HPV are 611 versus high risk HPV 16-18. These are the high risk ages also in our life too. So high risk 16-18. So cervix, that is normal columnar, changes to squamous because of chronic infections. And the last example of squamous metaplasia are the ducts. All the ducts of the lacrimal gland, salivary gland, breast and pancreas. All the ducts. What is the lining of the ducts? Cuboidal. The normal cuboidal lining changes to squamous metaplasia. Dekho, the word before metaplasia is the end lining. It changes to squamous. Why? Because of stones and vitamin A deficiency. This is squamous metaplasia. So we divided metaplasia into two types: epithelial and connective tissue. Epithelial metaplasia was again of two types: squamous and intestinal. Intestinal metaplasia, you know, is Barrett's esophagus. Versus the other side, that is connective tissue metaplasia. The classical example of which is myositis ossificans. See, the name tells you everything. Ossificans, bone formation in muscle because of trauma. This is bone formation in muscle because of trauma. This is our third cellular adaptation, that is metaplasia. And before we go further, let us see what it looks like microscopically also. Achha, first tell me, are the images important for you? Are the images asked? Yes, they are. And Bache, in the MDS segment, Each question has huge significance. This is because the number of government seats are as such lower. So we are fighting for an I'm not scaring you guys. I'm just telling you. I mean, and you know this as such. You know this. Each question is important, and we will ensure that you. This is the final push. I mean, you are going to have a beautiful rank, provided you sit and dedicatedly follow our sessions. You will, it's not going to be easy. I mean, let's be very frank about it. This is our first session. Our energy level is much higher. As the sessions keep on progressing, as the number of classes keep on progressing, our energy level is going to come slightly down. We are going to be slightly less concentrated and we'll feel like giving up. Especially the interns will be like कि यार एक साल ड्रॉप करके देख लेंगे, बाद में देख लेंगे, टाइम एज सच कम है. But this is where the significance of live classes and interactive classes will come in. Whenever you are feeling low, whenever you are like, tell me, I mean, it's not only about academic messages. You can always send a personal message on Telegram, and I'll 100% take care of it. Anything that is distracting you from studies, let it be anything academic or non-academic, contact us, and I'll do my level best to get you back on track. Next, so let's come back to our first image. What do we see here? Dekho, on left hand side, this is what the normal stratified squamous lining looks like. This is the normal stratified squamous, which is getting converted to columnar. All these are the columnar cells getting converted to columnar along with the presence of goblet cells. Columnar plus goblet cells. The minute you have these large white cells, columnar plus goblet, that makes it Barrett's esophagus intestinal metaplasia. This is Barrett's. And grossly, this is the gross image of Barrett's. See, you very well know the microscopy now. This is the gross image. Grossly, we are able to see the presence of velvety red mucosa. Grossly, we are able to see the presence of velvety red mucosa. This is Barrett's. Everybody, but please give me a thumbs up if all of you are comfortable with all the points, everything that we have done till now, all the points that we have covered till now. Everybody. Let me see if everything is working fine or not. Yes, it is. So this was Barrett's esophagus. Perfect. I always love the thumbs ups as well as more emojis. I mean, the students who have already done sessions with me know that. So this was Barrett's esophagus. Asha, before we go further, you tell me the diagnosis in this. Answer. What do we see here? Start with the parent organ. Tell me the diagnosis. Now there are two images in this, left and right hand side. This is of course brain. Showing left side is a nice normal brain. Where we are able to see the presence of gyri. जो ऊपर उठा हुआ है, the elevations, those are the gyri. The elevations are the gyri versus the depressions, which are the sulci. This is normal. What is happening on right hand side is there is narrowing of gyri. The elevations have become narrowed. There is narrowing of gyri. With widening of sulci. The gyri have become narrowed with widening of sulci. Diagnosis. This is atrophy. This is a case of cortical atrophy. So you tell me which is the most common cause of dementia in elderly. This is a case of cortical atrophy. I am telling you that this is an elderly patient. Which is the most common cause of dementia in elderly? Alzheimer's disease. Bang on right. So diagnosis, very nice. Diagnosis, Alzheimer's disease. So this gets us to our next cellular adaptation, that is atrophy. This gets us to the next one, that is atrophy. The name itself tells you, atrophy. It is a reduction in number and size of cells. Now atrophy is of two types, physiological atrophy and pathological atrophy. It is of two types, physiological and pathological. The classical example of physiological atrophy, the absolute classical example, is during embryogenesis. When we are in the womb of the mother, numerous structures form and involute, like thyroglossal duct and notochord. When we were in the womb of the mother, we had a tail. Unfortunately, now we don't. So, physiological atrophy during embryogenesis. During embryogenesis. Next example of physiological atrophy. Next example is thymus at puberty. Next example, which is thymus at puberty. Next is breast and uterus. Next is breast and uterus post menopause. All these are physiological atrophy. All these are physiological. During embryogenesis, thymus at puberty, breast and uterus post menopause. Versus, nobody will go wrong in physiological atrophy. Whenever you are studying, study it as this is common sense, this we know, this has to be remembered. Physiological atrophy was commonsensical. What you have to remember is pathological atrophy, and the first example of pathological atrophy is senile atrophy. Senile means it is associated with aging. Our usual first thought process is कि aging physiological होनी चाहिए ना, so senile atrophy should be physiological. नहीं बचे. Senile atrophy, because of aging, there is ischemia, there is reduced blood supply, there is ischemia. And which are the main organs affected? Brain and heart. There is ischemia of brain and heart leading to Alzheimer's disease. Alzheimer's is not physiological now, it is pathological atrophy. So the first example of pathological atrophy is senile atrophy. First example is senile atrophy. Next example is disuse atrophy. क्या use नहीं किया? No double meanings. Disuse atrophy. What did we not use? We did not use the skeletal muscle. Disuse atrophy of the skeletal muscle because of chronic immobilization. Because of chronic immobilization. The patient is chronically bedridden. He is chronically bedridden. He is in ICU or suffering from a chronic disease, as a result of which the skeletal muscle has undergone disuse atrophy. That is why in ICU we call the physiotherapist to move the limbs of the patient to prevent disuse atrophy. Next example of pathological atrophy is pressure atrophy. Pressure atrophy. What caused the pressure? What caused the pressure? Benign tumors or malignant? Just listen to this once. Benign tumors, they are well encapsulated. They grow locally. They enlarge and they grow locally. They do not infiltrate, do not metastasize. Benign tumors, they grow locally. They do not infiltrate, do not metastasize. Versus malignancies which are non-encapsulated. They tend to infiltrate and metastasize. So pressure atrophy kaun karega? Who will do pressure atrophy? Benign tumor. It is growing locally. So a benign tumor compressing the nerve intersupply of affected organ. That is pressure atrophy. And lastly is denervation atrophy. Denervation, the nerve supply has been cut because of fractures, trauma or surgery. These are the pathological atrophy. Another example of pathological atrophy is it can also be associated with protein energy malnutrition. It can be associated with PEM, protein energy malnutrition. First class. So bache, this takes care of our first subtopic in the chapter cell injury, that is cellular adaptations. This takes care of cellular adaptations. There were 4 cellular adaptations: hypertrophy, hyperplasia, metaplasia and atrophy. Now, if the cell is able to adapt, fair enough. Otherwise, it undergoes cell injury. So this gets us to biochemical mechanisms. This starts us with biochemical mechanisms of cell injury. First point, I want you only to tell me this. Which is the first organelle affected in cell injury? See, these set of questions, they are very commonly asked. Which is the first organelle affected in cell injury? सबसे पहले, which is the first organelle affected? You already know what is the most common cause of cell injury. It is ischemia, reduced blood supply. Most common cause of cell injury is ischemia. Ischemia, reduced blood supply, leads to hypoxia. Ischemia leads to hypoxia. It leads to hypoxia. Hypoxia is reduced oxygen. Which is worse? Ischemia ज़्यादा बुरा है कि hypoxia? Which is worse, ischemia or hypoxia? Which ischemia is worse? Ischemia is worse because that is reduced blood supply. Along with reduced oxygen, there are reduced nutrients also. So which is worse? Ischemia. Next point. First organelle affected. Angel bang on radio. First organelle affected, mitochondria. First organelle affected in cell injury, mitochondria. So the first biochemical feature of cell injury. What is the role of mitochondria in the body? It is the powerhouse of the cell. So the first biochemical feature is reduced ATP, occurring within seconds. Reduced ATP occurring within seconds. This reduced ATP in turn leads to reduced action of sodium potassium ATPase form. ATP is needed for sodium potassium ATPase. If the ATP reduces, the action of sodium potassium ATPase form reduces. Usually, if this is the cell, where is sodium more? Intracellularly, extracellularly? Sodium is more extracellularly, potassium is more intracellularly. Sodium extracellularly ज़्यादा है, potassium intracellularly. This disbalance is maintained by sodium potassium ATPase form. If the ATP reduces, it leads to influx of sodium and water and efflux of potassium. Very obvious, potassium cell के अंदर ज़्यादा था ना, so there is efflux of potassium. So I can safely say the first microscopic feature of cell injury is influx of water, that is cellular swelling. First microscopic feature of cell injury being cellular swelling. See, nothing is to be rectified in this. All these points are obvious. They are asked, all these points are obvious. First organelle affected, mitochondria. So the first biochemical feature, reduced ATP. Because of reduced ATP, there is reduced action of sodium potassium ATPase form, leading to influx of water. First microscopic feature, cellular swelling. Next, other biochemical features of cell injury. Other biochemical features are again important. What happens to cytoplasmic calcium? What happens to calcium in cell injury? It increases. There is increased cytoplasmic calcium. In cell injury, there is increased cytoplasmic calcium. Which in turn increased calcium obviously causes mitochondrial damage, fair enough, and also leads to activation of various enzymes like ATPases, endonucleases, and phospholipases. It causes activation of enzymes. Many enzymes get activated because of increased calcium. ATPases reduce ATP, endonucleases cause DNA damage, and phospholipases cause membrane damage. Increased cytoplasmic calcium. And lastly, देखो, calcium वाला point was obvious. If cytoplasmic calcium is increasing, that leads to activation of enzymes. And lastly, it is also associated with membrane damage. The damage to the membrane, it can either be to the plasma membrane damage. If this is the cell, the plasma membrane got damaged, leading to leakage of cytoplasmic contents, or the lysosomes inside it got damaged, leading to enzymatic digestion of cellular contents. This is cell injury. These are the biochemical mechanisms. So we had a look at 4 main biochemical mechanisms of cell injury. Reduced ATP, mitochondrial damage, increased cytoplasmic calcium, and membrane damage. With respect to MCQs, the main points seen in crash course, see, if it was a full class, we would have gone into depths, but that was meaningless. With the main MCQs that are asked is what happens to cytoplasmic calcium? It increases, and these 3 features. First organelle mitochondria, biochemical feature reduced ATP, microscopic feature cellular swimming. This is cell injury. So what we have seen till now is the cellular adaptations and biochemical mechanisms of cell injury. Cell injury was of two types, reversible and irreversible. But before I go to cell injury, it was of two types. It was of two types, reversible cell injury and irreversible cell injury. Irreversible cell injury was further of two types, that is necrosis and apoptosis. You know this. So before we go further in our topic cell injury, let's have a small 5-7 minute break at this point. Freshen up. See, in crash course we will be needing a break every 45 to 50 minutes because the course is faster. Let's have a 5 to 7 minute break. At this point. Do tell me your comments, as in give me a thumbs up if you guys are comfortable with the speed of the session and the app. Firstly, secondly, all inputs, everything is a slightly reduced, increase, more. Any doubts that you have, feel comfortable in sharing them with me in the break. So, next point, I know some students could not join in, so should I stop the session, in the sense that let me generate a new link after the break. Bache, you will have a new link. I'll put up a new link right now so that those who could not join earlier can join. So see you all in 5-7 minutes. Done. See you, bache. See you. Okay.